If there is a typo in your gene, does it spark a lifetime battle with cancer?
Although cancer happens because of a lot of genetic changes.
Cancer is a disease of genome, right? There are a lot of genetic alterations, there are a lot of genetic, you can say, mutations, number of things which is happening which actually are the cause of cancer.
Can your genes really decide if you can get cancer, or is it just a myth?
And which is hereditary, that you get from your
Parents.
or
Right.
your grandparents or your ancestors. If we had not done the genomics testing, I don't
Exactly.
think we would have thought about immunotherapy,
Right.
right?
Welcome to OncoFlix podcast. If there is a typo in your gene, does it spark a lifetime battle with cancer? To answer that, we have with us Dr. Mithua Ghosh, Director, Genomics and Precision Medicine at TriStar Sciences HCG Hospitals. Welcome, Dr. Mithwa.
Welcome, ma'am.
Thank you. Thank you, Dr. Lohit. Thank you, Dr. Kritika, for having me.
Thank you. So, can your genes really decide if you can get cancer, or is it just a myth?
So, see, it's a very good question. You know that we all know now that cancer is a disease of genome, right? There are a lot of genetic alterations, there are a lot of genetic, you can say, mutations, number of things which is happening which actually are the cause of cancer. But having said that, this is not the only cause because there are a lot of other factors like lifestyle, environmental factor, epigenetics, which all together play a role. So, yes, genes are one of the most important factors, but there is an interplay of other factors as well.
So, roughly, we always say that gene associated cancer, although cancer happens because of a lot of genetic changes, it may not really be coded in your genes. When we talk about genes that are the causative factor for cancers, roughly as we say in 10%, let's say two people have a cancer causing gene. Is it 100% sure that both will have cancer?
No. So, to have a faulty gene or a bad gene or a cancer causing gene doesn't mean that you will have cancer. That's a myth. Okay. That increases the risk of having cancer. You are more predisposed than the normal population who do not have that gene, right? So that doesn't mean having a faulty gene doesn't mean that you will have cancer,
Right.
but it
So,
increases the risk.
yeah. So two people having the faulty gene, one may still avoid having a cancer.
Yes, because as I said in my first, when I started the dialogue, that it's not only genes, it's definitely genes, but with that, there are a lot of interplays. What gene is there? So, what gene is faulty? At the same time, is there any gene to control that faulty gene? So, maybe the person who is not having cancer have some DNA repair genes or some genes which are repairing that error.
Right.
So he is not having cancer.
Right.
And then, as I said, there's a lot of interplay with environment, with lifestyle, with body weight, BMI. We all know there are a lot of factors which play a role. So it's a cumulative synergistic role.
So, we were talking about the environment and lifestyle. How does, probably, smoking or pesticides and obesity cause gene mutations? What is the trigger or, which can lead to gene mutation, which could again cause cancer? How is this, flow?
Yeah. So any genetic, or I would say any genotoxic insult to your body might cause DNA error. So it's like, I generally give an example to the patients whom I counsel. It's like when you're writing a mail, right? If I talk in layman's language, when you're writing an email to your boss, right? You make mistakes, you make spelling mistakes, you make grammatical mistakes. So when you're careful and when you're not in a rush, you revise your mail, you correct all those things. And your mail goes with a right message. But when you're careless or when you're in rush, you don't check your mails, and it goes with lot of grammatical mistake, lot of spelling mistake, maybe with a different message. So same thing happens in your body, right? Because of this genotoxic stress, which could be environmental, which could be radiation, which could be smoking. There are a lot of errors which happen in your DNA code. We all know DNA has a code which is ATCG, right? So there are a lot of spelling mistakes happen in the DNA code. Most of the times your body say, hey, halt, I have to correct these mistakes. And your body processes take place after those mistakes are corrected. But if those mistakes are not corrected, it leads to the accumulation of error, and that leads to the disease, whatever the disease is. And cancer is one such disease.
Yeah, so on one end, we have the damage caused by a lot of environmental factors. On the other end, there is repair. And we see most of the genetic causative factor for cancer is because of reparative gene deficiency also.
Yes.
So a lot of emphasis on genomics when it comes to cancer, but in what proportion of cancers do you see no changes or no mutations when you do the genetic analysis?
So as per our data, what we have generated, so there are two things, right? One is your somatic mutation, which is sporadic mutation, which you acquire over a lifetime because of multiple factors.
Right. So these are damages done to the gene because of our lifestyle.
Yeah, which is not repaired.
Right.
And there is one which is hereditary that you get from your
Parents.
or
Right.
your grandparents or your ancestors, right?
Right.
First degree or second degree. Now, when it comes to sporadic mutations or sporadic genetic alterations, there's no such number. Okay, it depends on the population, it depends on the ethnicity, it depends on the environment in which you are there. When it comes to hereditary, yes, 5 to 10% of cancers are hereditary, which comes from your first generation or second generation family members passed on, right? When it comes to somatic, there's no such concrete number which we can tell. But if you see our what data we have generated in HCG is about 70 to 80% of patients will have some or the other mutations.
Right.
Right?
Right.
10 to 20% might not have any mutations. Now, there are different implications. Having no mutations also sometimes is a good implications because some of the drugs will work which would not have worked if there were mutations.
Could you attribute the changes that can happen after genes to these cancers, the 20% cancers which do not show any changes in the genes?
So what you're trying to say, if there are no mutations, what
Right.
is the prognosis of that cancer
So-
compared to the
So if there are no mutation and if we are so sure that cancer is a genetic disease, so what contributes to cancer in those 20% in whom we are not able to detect
again
it?
that could be other factors because genetic is not the only factor, right? That could be other factor.
Again, cancer is
It-
multifactorial.
Yeah, multifactorial. It's a multifactorial complex disease. And we have almost 12 hallmarks, right? 11 to 12 hallmarks. It could be any other factor leading to any disruption of any of the hallmarks, right? So,
Right.
again, yes, it could be lifestyle, it could be environmental, it could be the body weight, it could be other comorbidities like diabetes and all, right?
So you were talking about hereditary. With respect to the Indian population, what proportion or what percentage of population will have hereditary risk of cancers?
So this is again irrespective of population, it is 5 to 10%.
5 to 10%.
5 to 10%. But however, some cancers are more vulnerable to be hereditary, like breast and ovarian, colon cancers, okay, and so gynecological cancers, prostate. Nowadays, we know pancreas, melanoma, thyroid. Melanoma, actually, I would like to correct, it's not that hereditary, but thyroids, medullary thyroid. So it all depends on little bit of type of cancer, the biology of the cancer, because even if you take in breast cancer, triple negatives, we have seen triple negatives have a lot of BRCA1 and BRCA2, both somatic and hereditary.
So if somebody's parents have had cancer, so is it very sure that it is a genetic linked cancer, and what proportion can be genetic linked? And how sure are we that the offspring or the child also will have cancer?
Yeah. So it's not always true that if the parents have, children will have, okay, because we know that 50% of the genes or alleles are passed on from either of the parents. So it depends on whether that child has acquired, because not every offspring will have that mutation. 50% of them 50% of the pregnancies will have that gene, right? So, it's required, or I would say, uh, we can't say that offsprings will have cancer. You have to test the parent, that is a proband. If their cancer is really due to some vulnerable gene which can be passed on to their offsprings, then the offsprings need to be tested.
Okay.
And then you can say, yes, they might have a risk of having cancer. Again, we cannot say that they will have cancer.
Right.
They have a risk of having cancer.
So this testing is next generation sequencing.
Testing is next generation sequencing.
Okay. So, many people feel healthy, okay? But do healthy people also carry dangerous gene mutations which could lead to cancer?
They might.
They might.
They might.
And in what proportion?
Because,
Approximately what proportion?
So that is statistically not. So what we know is hereditary cancer is 5 to 10%. Now, your query about healthy people having a vulnerable gene, maybe they have not manifested the disease now when you're seeing them. But there is a risk that they might manifest later, right? So they might not. So that again depends on having the gene is also not that important. What type of gene? Because even the cancer causing gene can be high penetrant, low penetrant, or mid penetrant.
Okay.
Okay. Again, if you are talking about a high penetrant gene like BRCA1 and BRCA2, it's always important to understand whether it's pathogenic, that is disease causing, or likely pathogenic, or it's a variant of unknown significance. Right?
So there can be changes which in the same gene,
Yeah.
but it may not really cause cancer.
Because the variety of or the type of changes what the patient has might be different. So it's not that simple. You have to find out through genetic testing what are the genes. Is it a high or mid or low penetrant gene? Is it a pathogenic, likely pathogenic, or a VUS? And then you have to take a call based on the family history, age, type of cancer, biology of cancer. You have to take a call to really call it a hereditary.
Okay.
So, madam, in your opinion, in India, you say 10% roughly of all cancers could have a hereditary association, but that 10% is a huge number. So, what proportion of patients do you think have been undergoing this genetic screening testing to find out if they really fall under the 10% so that the risk to the next generation could at least be quantified?
Yeah. So initially, to be honest with you, when I started working in genomics and started my lab, it was very less. It was about say 2 to 3% of the total population. I mean, which is coming to the hospital will go for the testing. The reason could be lack of awareness, lack of proper referral or cost, or a lot of factors. But now I'm seeing this number has increased. I mean, people know about this hereditary cancer, they read about it. So sometimes I've also seen maybe they have not been referred by the clinician, but just because they've read about it and they have self-awareness, they just walk into the office to get them tested or screened.
Okay, but so you do appreciate that over the years the awareness rate has
Yes,
gone up.
absolutely, absolutely, yeah, and it is going to go up.
In the year 2025, we see probably around 100,000 patients in our whole system of HCG. What proportion of patients do undergo genetic testing as soon as the patient walks into the clinic? As a diagnostic modality, what proportion of patients or what percentage of patients do genetic testing to decide on the treatment?
So again, I would say, I mean, it's very difficult to give a concrete number. It is,
But in your clinical practice,
yeah, it is still low, but it has improved. So again, when we started, it was hardly 1 to 2% of patients who used to come. But now, at least what I'm seeing is all patients are being referred by our clinicians that you have to do genetic testing. We have to know your. So the idea that knowing the genetic makeup will improve the treatment paradigm or management paradigm has come.
correct.
Okay, so number of referrals have definitely increased. Patients are more aware. They ask questions why it was not done before. Because I have been coming to this hospital for a long time. I've never referred to this. So this type of questions we are getting. Referrals are increasing. But again, there are a lot of other factors because most of the insurances don't cover the test cost. These test costs are little expensive side. It's not like doing a CBC or a test. So even the availability of drugs is a challenge. So many patients ask me, well, I have a mutation, but the drug is not available. So what do I do? So all these factors are playing a role. The reason why the numbers are not that high as we expect to be. But yes, referrals are increasing. People are becoming more aware.
Conscious.
Right, ma'am. So you said in 100 cancer patients, if we do the genetic testing, you will find some mutation or changes in 80 of them.
Yes.
Are all the 80 mutations that you're finding druggable, or do they have a drug available, or is there any other significance to those mutations that you find?
Yes. So that's a very good question, Dr. Kritika. So, no, all these mutations are not druggable, so not actionable. That's for sure. Because, and only to see the druggable mutation is not our intention. We want to see druggable. We want to see the prognostic factors.
How well they
How a patient will respond to any drug.
Right.
See, for me as a scientist, getting a negative report is also a good report. Because I'll give you an example. See, colon cancer. If colon cancer doesn't have any mutation, colon or colorectal, and the mutations are KRAS, NRAS, BRAF, right? The main, I mean, you don't have to do a big panel or so. If you know KRAS, NRAS, BRAF, you can start your first treatment. If those are negative, right, you have some drugs.
Right. That may work. Yeah.
Right? And for me, a genetic test is not only to say which drug to be given, it is also to say which drug should not be given.
Right.
Why do you want to waste your time and money in giving some drugs to a patient which he or she would not respond to?
Right.
Would be resistant to those drugs.
Right.
So genetic testing is done for multiple reasons,
Right.
not only to find out actionable mutation, druggable mutation, to find out the prognostication, to find out if there are any resistance mechanism which is working in the
Why
patient,
your treatment is not working.
why the treatment might not work,
Right.
what to give and what not to give.
Right.
So you see a lot of patients. Could you give an example of a patient whom you have created impact by genomic testing, and probably the responses have been amazing, which would have not been possible with the conventional treatments of chemotherapy, radiation, or surgery?
Yeah, there are multiple, Dr. Lohit. So if I remember a very recent case, it was a 10 years old, 10 or 11 years old child with glioblastoma. He was an African patient and had come to our hospital. He was on a wheelchair,
Okay.
right? And uh, so there were a number of treatments which has happened. I don't remember all of them. Maybe clinicians would remember surgery, chemo, and everything. And the child's condition was not improving. So then I was told to do a genomic testing. He was referred, and it was found, although glioblastoma, but it was found to be a hypermutated tumor. Okay, his tumor
So
mutation.
in layman terms, could you just tell hypermutated?
Yeah,
What is
so
hypermutated?
when we say hypermutation means he had lot of mutations in his sample, although he's 10 years old.
Okay.
We believe that number of mutations and genetic alteration increases as we age. But this was a different, because there were lot of mutations which has led to the tumor mutation burden to be high and microsatellite instability to be high. So it was a very immunogenic as well as hypermutated tumor. Now, as you know, and as a clinician, you might appreciate that immunotherapy is not the standard of care for glioblastoma.
Right. Right.
But our clinicians went out of the box, and because his lines of therapy had not worked, his child was treated with immunotherapy based on the genomics report.
Right.
And there was a
Phenomenal
huge,
response.
very good response. And the child, as per my last information from the clinician, child is doing good. He has
That's
revived his
wonderful.
cognitive
Yeah.
power.
I
and
saw
he's
this
on the
patient in
wheelchair.
Africa as well, and he's
Yeah.
still been doing very good.
Yeah.
Traditional glioblastomas only respond for 18 months. But here we have a patient living for almost like 4.5 to 5 years,
Yeah.
which is out of the box,
Yeah.
thinking and
If we
creating
had not done the genomics testing, I don't
Exactly.
think we would have thought about immunotherapy,
Right.
right?
Right.
And if I can give a very good example of a hereditary cancer, how it helped, because people say, well, if I don't have family history and nothing, why should I do a hereditary cancer testing? It's not needed. It's, you know, having a Pandora's box open.
Correct.
But I have a very good example, and probably this was our first or second case where we did. It was an AML patient, a young child, 8 years old AML patient. And
AML is nothing but it's a leukemia. It's like a form of blood cancer.
Yes. So this AML, this patient, so when we talked to that patient, clinician had referred to us. When we talked to the patient, we found out this patient had lot of family history. Father was AML, paternal aunt was MDS, another type of
Blood
myeloid
cancer.
blood
Right.
cancer. So there are a lot of family history of blood cancers in the family. When we said that we should do a hereditary cancer testing, and and it was a child, he was a child and he was very finicky, he was not ready to give saliva, not ready to give blood, so we had taken hair,
Right.
right, and then done a DNA extraction, did a test, and he was found to be RUNX1 positive. So just for the information, RUNX1 is a hereditary cancer gene for all this type of blood cancers, right? And so then we informed the clinician what needs to be done, because father was not alive, maternal aunt was not alive, but Ranix was there, and it is a bad prognosis also. So he needed a bone marrow transplant, right? And now who will be the donor? That was a question, because he has a hereditary cancer. Mother will not be tested here. Mother was tested. Mother was negative, but the sibling was a donor. So we tested the sibling, and sibling was also found to be RUNX1 positive.
Okay. So that predisposes the risk.
Yeah. So then we tested the mother. So mother was negative, and we did the HLA for her. So kind of 8 by 10 match, and mother was the donor. So this is how it helped.
Correct.
It not only helped this patient, but it also helped the sibling, because the clinician is still monitoring the sibling,
Right.
because he has a pathogenic RUNX.
So when we talk about genetic testing of an active tumor, of a cancer patient for the tumor, there is always this cost concern that comes up, both for the treating physician and for the patient. Now, how do you look at it? Is the cost of doing a genetic testing more than the benefit or the guidance of treatment that we will get out of it?
See, most of the patients, what I feel is it definitely helps in the treatment and reduce your final cost of treatment, right? If you do a, I'm not an economist, if you do a cost benefit ratio, definitely if you start the treatment, okay, with genetic testing report in your hand, it helps you to plan your treatment and management accordingly.
Can we say it helps in reducing the recurrences?
Yeah,
Because
definitely.
you have more information
Definitely.
about that particular tumor, and
Yes.
ultimately you're not spending for the treatment of a recurrence. So if you look long term, there is certainly a cost benefit because you know the tumor better now.
Yeah, because I think, Dr. Kritika, with you only, we have done a lot of head and neck cancers, and we have seen how head and neck cancers have lot of recurrent
Right.
markers, recurrent
Yes.
fat one, notch one, all this, and these are all published. There's no clinical trial to prove it. But if we are careful from the beginning that this is going to be aggressive tumor because it has all this type of bad genes, and you can decide your treatment
Right.
and be aggressive from that, and do your monitoring surveillance very aggressively so
Right.
that it does recur.
So there are hundreds and thousands of genes in the body. What is the minimal amount of genes which needs to be evaluated to come to a conclusion for a clinician and for a research scientist like you? Is there a minimal number what you would recommend?
That's a tricky question, Dr. Lohit. So I always say more the information, better is the your knowledge, and better you can manage. Uh, See, when we started, it was only the cancer specific genes, right? But while doing that, so again, I have some data which shows that if you do a small panel, say less number of genes which are only cancer specific, the
Small panel in the sense probably 20 genes?
say 20 genes to 50 genes, okay? The number of actionable or druggable mutation, I'm not even going to the prognosis or recurrence markers or anything. The number of only druggable genes, as per our data, is only 14 to 15%.
Okay.
Okay. But the same, so I did an, kind of project where I took the same 150 patients and did a small panel and a bigger panel, right? Just to see what more I'm getting. And this 14% which I got in small panel went to 49% when I did a bigger panel.
Okay.
Because bigger panel doesn't have all this. So I feel it should be, case specific. You have to take lot of considerations because again, insurance doesn't pay what type of cancer, what are the major mutations you might get, affordability and all these things, although we say it's not a factor, but we need to keep all this in mind and decide, take a decision what test needs to be done. But yes, to answer your question, bigger the
larger
better.
bigger the
Larger panel is a better information you get.
So, from our discussion, can we say that you would recommend genetic testing in every cancer patient, not just at recurrence or when all treatment option is ruled out, even when a patient presents to you the first time? Would you recommend a genetic testing for every patient?
Yes, as a researcher, as a scientist, I would. Although I know there are different school of thoughts. There, some people say after recurrence, because, but why should we wait for the recurrence to happen? And another thing I would like to say, actually, we are doing that. We are doing a diagnosis. Think about lung cancer. Will you be able to treat without doing EGFR testing?
Exactly.
Right.
Now, the method or the technology what you are using to do that testing might be changed. Might have changed. You might do a PCR testing, you might do just a small Sanger sequencing, or you might do a bigger NGS testing based on the cost and affordability. But actually, we are doing at diagnosis.
Correct.
Right.
Right. What we are doing, how we are doing depends on number of factors.
Right. So many doctors have the school of thought that you reserve the genetic testing if at all multiple
Patient
failures
record.
happen and you don't know how to treat the patient any further. So you do the genetic testing to find out if there is any target at all. But the approach which we have discussed right now, where you do the genetic testing right from the beginning to understand what that particular tumor is all about personalized and precision
So
medicine.
that your multiple lines don't fail.
Right. So you know at least whether certain drug that you're going to give is going to work or not.
Yeah.
And as you said, I think insurance approving these tests as a part of treatment becomes an absolute necessity
Exactly.
here, because you get a lot of information. Let's say even there is a 30% targetable or actionable mutation. Let's say another 30% guides you to the treatment. To that particular patient, it is 100%, right?
Yes.
You may overall it may look 30 or 60%, but to a specific patient, it makes all the difference.
Yes.
Totally.
I mean, we can take the example of Dr. Kritika. You guys see a lot of breast cancer patients which are HER2 positive.
Correct.
And we blindly give them Herceptin or anti-HER2, right?
Right.
But we know that 35% to 40% of patients don't respond.
Respond.
That's huge.
Because they have some coexistent or co-mutations
Right.
which don't allow them to.
Right.
Now the question comes that, well, if it is a HER2 positive, do we say to the patient that we'll not give you Herceptin? No, because
Right.
first line is Herceptin.
Right.
What I say is, yeah, definitely give Herceptin, but combine with something else
Right.
so that there is a backup.
Right.
Correct.
Yeah.
For example, when you take an example of lung cancer, if two lung cancer patients have the similar mutations, consider EGFR mutations. We know that they may not respond the same.
Yes.
Okay, though they have the same kind of mutation, same kind of cancer, same kind of stage, yet they may respond differently.
Yes.
Why is it different, and what is your scope of thinking from a scientist perspective?
So that's what we have to be very careful when we write the report and when the clinicians read the report. So what happens is, first important thing is what is the mutation. So what you said is EGFR. Now EGFR can have different mutation in different regions. I will not use to be in layman's language, in different regions in the whole gene. All those regions are not good mutations. Some are good mutations, some are bad mutations. So we need to see what are good. If there are bad mutation, we should not even give those drugs. Only if there are good mutations, we should give the drug. This is one. Second thing, what we see as a scientist is what is the, so again, to be in layman's language, how many mutations?
Correct.
So one patient might have, say, 50% variant allelic frequency, which means there are 50 mutated cells in 100 total normal cells, right? And, the other person might have only 1%, which is
Right.
unmutated
Very-
cell,
Right.
right? So which means the mutations are emerging. There, drug might not be that effective,
Right.
right?
So the proportion of cells
Yeah,
that
that
are
is
mutated.
important. Those are things we have to see. The third thing is, when you talk about response, it also depends when are you monitoring the response. So your minimum, what I understood from you, is 6 months, right?
Correct.
We'll do another PET CT to find out. So by that time, there might, so cancer is very smart. I mean, cancer
It's very
cells are very
scientific as well.
smart. They try to have escape the mechanism. They have an escape mechanism. So when you are starting those drugs, these cancer cells will escape the mechanism, and there will be some resistant mutations which will come up, like MET, RET. Even on target, EGFR itself will mutate to
Correct.
have some resistant mutation. And if the patient develops those mutation, he will not respond. These mutations can be de novo also. So it can happen with EGFR de novo, new,
Mm-hmm.
not
Oh,
as a not because of treatment of TKI.
correct.
So if there are de novo mutations, so again the point comes: should you do one gene or a small panel or a bigger
Big
panel?
man.
If you do one gene, you will not come to know that there are some bad mutations
Mhm.
also, right? And you
Right.
treat, and the patient doesn't respond.
Right.
Interesting.
So what is your definition of this CRISPR? And there is a lot of hype about it. Can it really delete all bad genes?
So yeah, CRISPR is an upcoming field. There are a lot of upcoming fields coming up. Uh, that they can silence the cancer genes, cancer causing genes. They can activate the the genes which will prevent cancer. But I feel it is still in research phase. We need to evolve a lot. We need to have a lot of clinical trials, lot of research which is proven, has a track record of showing a good result, and then maybe we'll achieve something. But yes, these are all upcoming fields and technologies which we should get into as research.
CRISPR is one technology, but will we ever reach a stage where we can switch off the gene to cure cancer?
It's difficult, Dr. Lohit, again, as a scientist, what I feel, because let's take example of P53, right? You guys are seeing P53 mutated, and it's known factor in 50% of cancer. But we are still not able to develop a drug
Mhm.
for P53. Why? Because it's a guardian of genome. It's sitting at the top. If you switch it off, there'll be many other
Correct.
things which will be switched off, right? And that might affect the other things, non-specific switch off of other useful genes. So it's not easy. A lot of research needed to
And
understand
I think
this.
with respect to AI, quantum computing coming to the fore, there are lots of permutations and combinations which can
Yes,
be done, where probably in the next decade there's going to be, we could be very, very close to that.
sure.
I
Yeah.
think, these are exciting times, I think,
Yeah,
with
these are
respect to tech.
exciting
Yeah.
times. Yeah. I think cancer is a field which where we have to keep evolving,
Correct.
because the disease itself is multifactorial, complex, complicated. Every day, actually, every 10 years, we are coming up with new hallmarks, right? So as a researcher, we have to also do a lot of research. As clinicians, definitely, will need your feedback for doing all this research. And hopefully, one day we'll be able to be there to conquer cancer completely.
Absolutely, madam. So we spoke about these hereditary cancers or gene-related cancers that is passed on via generations. We also spoke about the importance of genetic testing in a patient who has cancer. Now, what about detecting cancer cells in blood, as we call as circulating tumor cells? Will you be able to detect a recurrence or a cancer coming back even before we can see it in scans using this blood test?
Yeah, so what you're saying is popularly known as liquid biopsy now. So there are multiple technologies which are coming up. There is circulating tumor cells called CTC, circulating tumor DNA called cfDNA, which will enable you to understand whether there are circulating tumor cells. Uh, Now, whether, see, in certain cancers like breast, colon, it has been proven, right, that if there are circulating tumor cells, there will be recurrence, there will be metastasis. And this is a FDA approved test, which
Mhm.
they have put a cutoff also. For breast and prostate, it is five CTCs, and for colon, it is three. It is not, it has not been established in all cancers, because there are specific cancers which can shed these tumor cells, whereas epithelial cancers, there's some cancers which do not, like glioblastoma.
Right.
Because of the blood brain barrier, you will not get
Correct.
cancer
Cells in the
cells in
blood.
the blood.
Mm.
So this technology is very, very promising, but with challenges.
Correct. But can you also detect, the cancer cells in your saliva? Like, for example, we in India have a lot of identified cancer because of tobacco chewing, smoking. Do you think we have the tech to detect cancer via saliva?
Ideally, it should be done, but generally, the instruments and all what we are using do not have that capability to do from other body materials. But yes, people are isolating from saliva, from urine, from stool, cfDNA, and circulating tumors.
Interesting.
Yeah, so they are.
So I think it's been a very exciting discussion. Okay, and uh, there is so much amount of evolution with respect to genomics. We have probably in the last decade, we were not inculcating this genomic parameters into our clinical practice. Now we have evolved into usage of genomics into our clinical paradigm and probably using it in proper decision making as well and creating impact in patient lives.
Yeah.
So in the next decade, I think it's going to be much more. Probably as an oncologist, we will maybe using more amount of genomics into our staging system itself rather than stage
Yes.
1, 2, 3, 4. It will be more amount of personalized, highly precise genomic staging, which can be extremely precise and personalized for individual patients rather than uniform treatment for all patients.
That's a wonderful perspective. And also, with respect to hereditary screening, I think any young breast cancer or patients with a family history, now the rate of reference for genetic counseling and subsequent testing to be done has increased. And I think it's near 100%, I should say.
Yeah.
So, whenever we find a case like this, so that has been the evolution both with respect to screening perspective and treatment perspective.
Yeah.
And
Even the guidelines are evolving and they're changing. Now for breast cancer, anybody below 65 need to be tested.
Right. So it was once used to be young breast cancer,
Yeah,
which was
yeah,
40.
yeah.
Now it's
This will
65.
be 65.
And congrats to you and your team and HCG Hospitals for getting out the first Indian genomic profiling and to be published in one of the prestigious nature journals.
Thank you. Thank you so much.
It was wonderful having you here, madam.
Thank you.
Thank you.